All right. Okay, let's go away. Okay, my name is Jason Vanstone. I am the research scientist for stewardship and clinical appropriateness. I work with our antimicrobial stewardship program in Regina, and today that is what I'm going to talk about what antimicrobial stewardship is, and why it should be important to clinicians, and things that we can do to be better stewards of our antibiotic resources. So I like to introduce the concept of antimicrobial stewardship by talking about board games, which are one of my favorite hobbies, and my favorite board game, which is called Pandemic. So this is a game where it's a cooperative game where all of the players work together to try and beat the game. And this is what the board looks like. So you can see you've got cities of across the world sort of dotted there, and then there's these four different diseases represented by these different colored cubes, and they spread out throughout these areas and basically just try and kill everybody on Earth. And the player's job is to try and stop that from happening. And so the players each get a different role. So you might be a scientist or a researcher or a medic or a quarantine specialist. And they each have unique abilities that they bring together as a team to try and fight the game. But of course, the game fights back. So there are epidemics that happen as you draw cards, and it causes the diseases to expand and move into different areas. You can get mutation events, and then a new disease shows up. But eventually, the players can win the game if they find the cure for all four of these diseases. And the game wins if basically you have far too many outbreaks and too many people die, and you're not able to do your job. And so it's this whole idea of having this sort of multidisciplinary team, the players working together to try and fight off these various diseases. And it's to me something that's very much similar to what we're trying to do in the world of antimicrobial stewardship. So antimicrobial stewardship programs are essentially multidisciplinary teams of experts, and our job is to try and slow the development of antimicrobial resistance around the world. And we do this by promoting the appropriate use of antimicrobials. And there's a number of ways that we do that, and we'll talk about some of that. But this idea of antimicrobial resistance is key. That's the thing that we're fighting against, and it's the thing that is going to cause big problems for us in the future if we don't sort of get a handle on our use of antimicrobials and our inappropriate use. So I'll just talk real quickly about antibiotic resistance because this is kind of a key theme. The idea here is that if you have regular old run-of-the-mill bacteria, nothing special about them, when you throw antibiotics at these guys, they die, which is great. That's what antibiotics are for. Antibiotic resistance is when you have bacteria that basically get some sort of a genetic mutation that provides them with resistance. So it might be a mutation in their main chromosome. It might be something, usually more commonly, that's on a plasmid, which are these little extra pieces of DNA that bacteria can have. And the mutation that they have provides resistance to whatever antibiotic. And they could have multiple mutations giving them resistance to multiple different antibiotics. And those types of superbugs become really difficult to treat. But that's really all that antibiotic resistance is. It's just this evolutionary happening from evolutionary pressures of us treating bacteria with antibiotics. And we know that the more we use antibiotics, the more antibiotic resistant bacteria we see. So it's our use of these antibiotics that is driving a lot of this pressure to evolve these genes in these bacteria. So you can see here, this is data showing in blue, basically penicillin prescriptions throughout the year. This is data from the US. And so you can see there's high use of antibiotics in sort of the flu season months, January, February, March. And then it gets into summer and people spread out and, go outside and enjoy their time and have fun and leave each other alone. And then we all get back together in the fall and school starts up and everyone's back at work and we start coughing and sneezing all over each other and spreading bacteria and viruses again. And so we start to see more antibiotics being used. So we have these seasonal variations. And then if you look at in orange here, this line is the resistance in bacteria to those antibiotics. And so even though there's about this 1 month lag between the two, you see a similar pattern. So when we have high use of antibiotics, we see high antibiotic resistance in those bacteria. And as we use fewer antibiotics, we see less antibiotic resistance in bacterial populations. So we know that as humans, we can affect this. We can change how much antibiotic resistance we see by simply using less antibiotics. So why do we need antimicrobial stewardship? I've got a few slides that will hopefully make that point. Number one, we use a lot of antibiotics. As I just said, we know that is going to affect antibiotic resistance. So the data here is from the CARS report, the Canadian Antimicrobial Resistance Surveillance System. It's their 2020 report. And so in 2019, we see here that Saskatchewan was the second highest user of community prescribed antimicrobials, if you combine the maritime provinces together. So previously in this report, they had taken New Brunswick, Nova Scotia, Prince Edward Island, and Newfoundland, Labrador, and combined them together as one group. And so they were per capita, basically, or per 1,000 inhabitants, the highest users of antimicrobials. And Saskatchewan has traditionally been number 2 on that list. So we're, kind of across the provinces and territories, we are the second highest users of these community prescribed antimicrobials. So things that you would get at a community from a, family physician, things that come out of community pharmacies, those types of things. So again, the fact that we use a lot of antibiotics, particularly in Saskatchewan, where we don't have an especially large population, means that we are at risk for seeing more antibiotic resistance amongst our population because of our increased use compared to other places. And it's not just a problem in community in terms of use, but also in purchasing data from Canadian hospitals has also increased. So if you look between 2014 and 2018, and I just pulled this quote out of the report, just raw antimicrobial doses purchased by hospitals has increased by about 30%, or 33%. And if you standardize that to population size, there's been about a 27% increase. So we're purchasing more antibiotics in hospitals. And then along with all of that stuff, we also have seen then incidence, an increased incidence of healthcare associated antibiotic resistant organisms. So these are bacteria that are associated with people being in hospitals, and they are antibiotic resistant, and we've seen an increase in those. So you can see on the bottom left here, they're showing this is methicillin resistant Staphylococcus aureus bloodstream infections. So whether you look at hospital acquired and community acquired together, or breaking those two apart, we see increases in those. Vancomycin resistant bloodstream infections. This one over here is for carbapenemase producing Enterobacteriaceae. So we see increased colonization amongst individuals, but also lower rates of infection, but still rising over those 4 years. So we're seeing the effects of, the more antibiotics we're using, we're seeing more and more antibiotic resistant bacterial infections. And so there was a report done in 2014 in the UK where they did some, analyses and tried to come up with an idea of a projection about what happens if we don't do anything. So if we don't change the way we're using antibiotics and be better stewards of this resource, their prediction was that by 2050, we would see more than 10 million deaths a year from antibiotic resistant organisms. And just to put that in context, so right now, we see about just over 8 million deaths a year from cancer globally, and about 700,000 deaths from antimicrobial resistant organisms. And so if we don't change the way we're using antibiotics and do better, that number could become that 10 million. And so that would eclipse the number of deaths we currently see from cancer. And so when you think about this, that takes us really back to, kind of the dark ages of medicine, before we had antibiotics. So, in the last 70 years, we've been able to deal effectively, for the most part, with bacterial infections through the use of antibiotics. But if we start to see this, the rise of antibiotic resistance, and we don't have effective drugs to treat these things, we'll actually go back in time to a place where, at one point, 50% of the human population was dying from infectious diseases. And we could go back to a time like that if we don't have these antibiotics available, and it could change the face of medicine in terms of the type of interventions and things that we can do. So not a place that we want to be. So how do we start to tackle this? What is it? What do we do? And particularly here, I want to talk about what antimicrobial stewardship is, kind of in a clinical context. And I like to sum it up with really 5 questions. So the first one is an antimicrobial necessary? That's something that every prescriber should ask themselves before providing an antibiotic prescription order for their patient. Does my patient have a bacterial infection? And therefore, do they need an antibiotic to treat this? And if they do, that's fine. That's why we have antibiotics. But we want to make sure that we're using the right drug, the right dose, the right duration, and that we're treating that patient in the right route, so IV or oral antibiotics, whatever it may be. So I just want to highlight a few bits of data that we've collected in the Regina area recently to kind of show where there are areas where we think there's room for improvement in how we're using antibiotics. So just on that first question of, is an antibiotic even necessary? One of the things we've done quite recently is looked at inpatients in Regina who have COVID-19. And we were looking at the number of antibiotic prescriptions, or how many have been provided antibiotic prescriptions within 48 hours of admission. So we're looking at patients just between November of 2020 and April of 2021. And overall, we found that 82% of our hospitalized COVID-19 patients in Regina had received an antibiotic within 48 hours of admission. And again, for context there, when you look into the literature, we're seeing overwhelmingly that it's a very low number of patients who actually have a concomitant or a secondary bacterial infection from with COVID-19. So less than 10% in a lot of cases. So when you look at that there, we're treating 82% of these patients with antibiotics. Only about 10% of them we would expect to have an actual bacterial infection. And so very likely that there are a lot of patients receiving unnecessary antibiotics for what is really a viral infection, COVID-19. So something where we think we've got some room to improve in terms of how we're treating these patients, especially early on, and especially if those antibiotics get carried on beyond sort of the 2-3 day mark. And it's something that we've seen over time. So this isn't just like, there was one bad month. Like, it was pretty consistently around 80% for all of the months that we looked at there. Another thing, so if we go out of the hospital and look into communities, so we've been working with some community clinics in Regina, and we're able to collect information about what they're prescribing for by looking at the indications that are entered into their EMRs. And so the pie chart here shows all the different colors represent different indications. I've just labeled the ones that I want to talk about. So upper respiratory tract infections and lower respiratory tract infections. And so when you look at that, for example, this is one prescriber, and out of all of their antibiotic prescriptions, respiratory tract infections make up about just under 13% of their indications. And so when we compare that to another provider, you can see with this person, if you combine those two together, that's 64% of their prescriptions are for respiratory tract infections. And so when we talk about respiratory tract infections, these are generally, most of the time, the vast majority of the time, these are viral in origin. And so do not need antibiotics. And yet for some people, we're seeing that, almost 2/3 of their antibiotic prescriptions are for respiratory tract infections, compared to other people where 12-13%. So when we look at this type of data, it gives us, it puts the question where it's like, is there the potential for some inappropriate use going on here? Is there someone who's providing antibiotic prescriptions for people with viral respiratory tract infections that might be unnecessary? So that gives us the impetus to go in and try and do some work with these clinicians and see if we can improve prescribing habits. The last example I'll give is to try and speak to that appropriateness piece about, are we getting the right drug, the right dose, the duration, and the route? And really this question comes back to indications, because we need to know what the antibiotics are being used for to really start to dig into some of that information. And so this is the data that I'm going to show is actually from, we've had pharmacy students who've been working with our program in Regina here for a number of years, but this data just comes from January of 2020 through to April of 2021. And so these students have reviewed over 1,000 antimicrobial prescriptions in the hospital system. And we wanted to ask, are people putting their indications with their antimicrobial order? Because from an antimicrobial stewardship perspective, this is a very important piece of information to allow the entire care team to better understand why antibiotics have been prescribed and allow them to make those decisions about de-escalation of therapy or deprescribing, whatever the case might be. And so when we looked at that, 64%, so almost 2/3 of those orders did not have an indication written with the original order. 36% did, so that's something, but again, something where there's likely room to improve in terms of hospital prescribing, ensuring that people are getting those orders, the indications with those original orders. And we wanted to expand this just to say, okay, if the indication isn't with the original order, is it at least somewhere in the chart? Happily, I guess, 83% of the time, there is an indication somewhere. But for anyone who's a busy clinician, you know, the likelihood of someone searching through the many different areas of a chart to try and find where, you know, a reason why this person was provided, why that patient was provided with an antibiotic is somewhat low. So it's really best to have that order, the indication with the original order. The other piece that I want to highlight here is that 17%. So 1 in 6 of the orders, the students could not find an indication anywhere for the antibiotic. So no one had any idea why this patient was on this antibiotic. And it's a small number, but to me, that's still, you know, a significant number of patients, 1 in 6 that, or of orders anyways, that don't have an indication with them. And it's probably somewhere where we can definitely improve that piece at the very least. So some ideas for improvement, things that we as an antimicrobial stewardship program have been working on and are trying to tackle. So bigger picture then, what does an antimicrobial stewardship program do? So obviously, as you saw there, data collection, data management, trying to understand where the problems are and where we have room for improvement. Those are big chunks of what we do. Audit and feedback, so we take that data, we go and talk to prescribers and try and help them understand the data so that we can get the behavior changes. So that's another big piece, working in behavior change. We do some research, we do, you know, implementation science, those kinds of things. Education is a big piece of what we do. So talking to people, whether that's clinicians, the general public, just trying to get people aware of the problem. We do clinical reviews. So we have antimicrobial stewardship pharmacists who go out and review patients in the hospital system, ensuring that they're getting appropriate antibiotic treatment. Network building, collaboration are big things. We have many different people that we work with. Of course, we have a core team for our antimicrobial stewardship, but as I said, it's that multidisciplinary approach. So we've got collaborators in departments throughout the hospital, pharmacists, nursing, physicians, right? So just trying to connect with people and get everyone involved to take some ownership of this problem so that we can all move forward and tackle it together. So the last couple of things I'll leave you with is just some resources for antimicrobial stewardship. So trying to give you some tools to use to be better antimicrobial stewards. One of the big ones in the Saskatchewan Health Authority, we have the Spectrum app available. And so this app can be used as an antibiogram. So it's got antibiogram data loaded for all of the different areas in the province. So you can download that from whichever app store you use, whatever device you use. It's free. You just sign in and pick your area, and it will supply you with the antibiogram. So you can use that for helping to, especially with you know, empiric therapy and stuff like that, helping you to get an idea of what the resistance rates look like amongst different bacterial populations in your area and for your patients. It also has some sort of clinical guidelines and things like that in there as well. So it can be a very useful tool for more than just antibiogram purposes. So definitely check that out. If you're old school, you can scan the little QR code here, and that will actually take you to our library, the SHA library website, where we have PDF versions of the antibiograms for all the different former health regions as well. So you can get those there. Again, it's all the same information that's already in the Spectrum app as well. So I highly encourage everyone to use Spectrum, make use of that. Another great resource is Choosing Wisely Canada. So again, you can scan the QR code there, and it will take you to the Antibiotics Wisely Toolkit, which is a wonderful toolkit for patients and prescribers alike, for people to get more information. There's, depending if you're primary care, long-term care, acute care, there's different recommendations and highlighting some of the key areas of antibiotic misuse and inappropriate use. And then they provide tools as well. And one of the tools that I like to highlight is the viral prescription pad. So that was something that we worked on in the Regina area here, and has sort of made its way through chains of organizations to get to Choosing Wisely Canada, and it's something that they promote. So particularly for primary care providers, it's a great tool to engage patients in the conversation about appropriate use of antibiotics when they show up to your clinic with like a viral illness, especially upper respiratory tract infections, things that don't need antibiotics, and maybe the patient needs a little bit extra help understanding why that is. So yeah, great tools that you can use. Check them out at that website there. A few other resources just to highlight. So Bugs and Drugs, the Sanford Guide, the Infectious Diseases Society of America, all great resources that you can use to get more information about antibiotics and what they're used for, and sort of big picture ideas about antibiograms and resistance and that kind of thing. And I will leave that there. So if there are any questions, you can definitely reach out to us. Antimicrobial.stewardship@saskhealthauthority.ca is our general email address if you have any questions. Thank you very much. Okay, stop recording. Hey, look at that, 10 o'clock even.